good afternoon, good morning, good evening to everyone. Thank you so much for joining us for this first day of the Multiple Syndemics of Tuberculosis Symposium. Before beginning the program, I'd like to give an acknowledgement of country. We acknowledge the traditional owners of the land on which many of our colleagues meet today. I would also like to pay my respects to elders past, present, and emerging. Australia always was and always will be Aboriginal land. Normally, I'd be joining the symposium from Redfern, which is a suburb in Sydney, on the traditional lands of the Gadigal people of the Eora Nation. But today, I'm joining from the TB and Lung Disease Hospital in Can Tho, Vietnam. And Vietnam is actually home to 54 different ethnic groups, and I would like to acknowledge their stewardship and care for the land and the waters that are hosting me right now. So welcome once again to all attendees and speakers to this, I think, really exciting symposium on the multiple syndemics of tuberculosis. My name is Emily McLean, and I'm a research fellow / lecturer in the Faculty of Medicine and Health at the University of Sydney in Australia. I work with Greg Fox and others. I think I see Ben Murray on the call. I'm also part of the Sydney Infectious Diseases Institute, and I chair the Next Generation Committee within the TB Centre for Research Excellence, which is a network of TB researchers working across Australia and the region. I'm also part of Stop TB Partnership's New Diagnostic Working Group, and as such, most of my own work is focused on TB testing and diagnostics, whether that's test evaluation and implementation, knowledge synthesis, and I spend a lot of time thinking about test evaluation methodology. Just a plug, if anyone is in Hanoi over the next few days or Phnom Penh next week, I would love to meet up for a coffee and exchange ideas, so just let me know. I'd also like to extend a big thank you and congratulations to Dr. Michaela Coleman for conceptualizing this event and leading the organizational charge. Even though she says it's not a lot of work, I'm sure it is a very large amount of work to put something like this together. Michaela has sorted us a really fantastic, diverse list of speakers from across regions, and I'm sure we're going to be hearing talks of high relevance to anybody who's interested in TB. So the purpose of today's meeting is to discuss the ways in which TB interacts with non-tuberculosis conditions as a biomedical and social and epidemiological reality. As we know, the implications of this biosocial medical epidemic are felt more by affected families, especially in low-resource settings. And TB may impede the wider health, socioeconomic opportunities, and overall well-being of people and their families who are suffering from the condition. So in this symposium, we're meant to highlight what we know about TB plus other conditions, showcase upcoming research, and give consideration to how our thinking and practice of TB screening and care needs to change and adapt to help TB-affected people and families not just survive, but also thrive in their life during and after TB. So just some housekeeping administrative notes. The symposium is going to be held for 2.5 hours a day, today, tomorrow, and Friday. And we'll follow the same general format each of the 3 days. So there'll be welcome and admin notes like I'm giving now. We'll have the first session on syndemics plus questions. We'll have a little break and then hear from a TB survivor. The final session will be on integrated TB screening and care, and then we'll end with a panel discussion. So please stay online for the discussion to ask your bigger cross-presentation questions. We hope to have things be quite interactive. So I'd like to turn over to Michaela, who's stepping in for Professor Annika Hessling, and she'll be chairing our first session on tuberculosis syndemics. So thanks for your attention and looking forward to a great 3-day virtual event.
Thank you so much, Emily. It is a pleasure to step in for Annika today, and I will get us right to the point. It's a delight to introduce our first speaker of the Multiple Syndemics of Tuberculosis Symposium, Professor Madhavi Bhargava. And Madhavi is a professor at the Department of Community Medicine in Yanapoya, and also the Center for Nutrition Studies. She co-led the rations study and has worked in the field for more than 25 years.
Thanks again. Good morning, good afternoon to everybody. And so what I will do is for TB Nutrition Syndemic session, I will first talk about a little bit about my experience of working in rural and tribal India, which led to some observational work and then led to the rations trial. And briefly about the overview of the rations trial, most of you must have read it, and the impact and a bit of a sneak peek into the upcoming TB nutrition guidelines. So I entered into a not-for-profit organization as a very impressionable young doctor in rural tribal area of Chhattisgarh, central part of India, where we got an abandoned irrigation colony for 30 years lease. We converted it into outpatient, inpatient outreach work. We had outreach work in 52 villages where we trained village women into giving primary care. So, and it was, apart from tuberculosis, it included, nobody had the luxury to specialize and do only their specialty work. So this was my previous avatar. So apart from tuberculosis and other infectious diseases, we also saw a lot of surgical problems. And what I would like to point out is this slide in the picture in the middle, where 3 children, different varying ages, but almost similar weight, having chest tubes due to empyema. So what we realized about tuberculosis when working for 10 years there was that it's a disease of family and communities. It was very intimately related to poverty, undernutrition, and the morbidity was very high in those who were undernourished. And what we did was we provided patient and family-centered TB service, provided nutrition support. None of this was part of any guideline at that time, and tried and documented the gaps in diagnosis, treatment, and prevention of TB. So apart from various advocacy articles, 2 important articles I would like to mention was the one where we reanalyzed the Papworth experiment of pre-chemotherapy era, where more than 300 household contacts in 135 families were provided instead of isolation. They lived with their families and provided food, good occupation, and food security, and saw that there was 6-fold reduction in TB incidence. Another was one of the largest cohorts, which was gathered in where I worked in Jan Swasthya Sahyog, where we saw that in more than 1,500 patients with tuberculosis, there was, because of severe undernutrition, there was almost 2 to 4-fold higher risk of mortality. And we reported weights and BMI in them. We did not have any great tools at that time, but this was probably the largest cohort which had weights recorded. So when we first reported the BMIs and weights as low as 15 and 16 in women and men, and we were told that that was because it was Chhattisgarh and because it was a state which had a lot of poverty and undernutrition. But in 2016, when the programmatic data was published, we found the weights were not very different. And just remember these weights in 2013 and 16. These are not very different from what we are going to see in rations trial in 2000, which was reported in 2023. So what we learned in JSS was a lot of busting of binaries, and that people don't come with singular problems. And we need to be clinicians as well as public health persons. Treatment is not, it is in all these binaries of treatment versus prevention, medical versus surgical, communicable, non-communicable, all these were busted. One of the important milestones, we thought that we cannot work in isolation. So we need to bring a lot of people together, all stakeholders together. So we led a workshop in 2016 where we had programmatic persons, nutritionists, dietitians, civil society members who gathered and discussed and contextualized the WHO 2013 document And this led to the publication of guidance document of nutrition care and support for patients with TB. And this led to the mainstreaming of nutrition TB discourse in India. It stays there in the website. Of course, this document is being revised at the moment. Another simple tools that we devised were BMI charts, because people were, although measuring weight, sometimes measuring height, but no meaningful interpretation was being done. So people, the primary care providers needed support to identify BMI, make some meaningful interpretation. So the app tells, even the BMI chart tells how much weight the patient needs to gain to reach acceptable and ideal body weights. This app is part of the national program now. So two important questions that remained after all these observational work was that, can we reduce TB incidence in high-risk group by addressing undernutrition? And can we reduce TB mortality in patients by addressing undernutrition as their comorbidity? So whatever I tell about patients today is on behalf of a very large team that worked very hard, especially because it coincided with COVID-19, as you can see, from 2019 to 22. And this work was supported by Indian Council of Medical Research. Jharkhand, where I worked, I'm in South India. This was in Eastern India. We traveled almost every 1 or 2 months and stayed there for week to 10 days. And it's a very beautiful state with a lot of forest cover, but a lot of disparity, poverty, and issues of livelihood and access to health or anything, I would say. Accessibility is a big issue. So for the two sets of questions, we had two sets of study populations. Patients with tuberculosis, microbiologically confirmed, 2,800, and their household contacts. The primary objective was to look at the difference in TB incidence, the first set of questions, and the secondary objectives was in the second set of population, the patients, where we wanted to look at reduction in TB mortality with nutrition support, weight change, loss to follow-up, and side effects. The intervention was dry food ration food basket, which for ethical reasons was provided to both patients in both the arms that gave 1,200 kilocalories and 52 grams of protein per day, along with micronutrients. In the intervention, the family members received rice and pulses and multivitamins that provided 750 kilocalories and 23 grams of proteins along, and this was halved for child contacts less than 10 years. So these are the glimpses of the measurements and some of the sub-studies which are in various stages of reporting now. Straight away coming to the main outcomes, we identified around 218 household contacts with incident TB over 22,000 person-years of follow-up, and 96 in intervention arm, 122 in the control arm, which was like, if we look at the adjusted incidence rate ratio, 0.61 for all types of TB and 0.52 for microbiologically confirmed tuberculosis, which is almost 39 to 48% reduction in TB incidence. We had low loss to follow-up and withdrawals, mainly related to COVID-19. And very few, and there were some co-prevalent cases, that is first 2 months of the enrollment. If you look at the second set of population, the patients, unfortunately, this was not a trial for the patients, it was a cohort. The treatment success rate was 94% and cure in 49%. A very modest weight gain, I would say, 4.6. Probably because of COVID, probably because of food sharing, and unfavorable outcomes were much less, and there were 108 deaths. Speaking about the deaths, if we compare it to the cohorts, the multi-state cohort within the country in the programmatic conditions, if we look at patients with all kinds of weight, it was almost 35% reduction in mortality. And if we look at patients with weight less than 35 kg, this was almost half what was observed in the other cohort. And you can see the clear gradient here for case fatality and patient weights. So higher the weight, less was the mortality. ECOG is basically functional score, where 0 is people like you and me who can walk, and 4 is bedridden, chair-bound. And you can see that it was almost 40% in those with category 4, which is a very important, I would say, a primary care tool to identify those patients who are going to die. And if we look at the ECOG, and one of the patient-centered outcome, I would say, if there were only 3% patients who were able to work at baseline, almost 75% patients returned to work at the end of intervention of 6 months. So looking at the impact, although when we started during the COVID, we almost thought that we'll have to stop the trial. We continued somehow. And fortunately, we were able to publish in good journal. It had an impact. It's part of UpToDate now, alongside of BCG for TB prevention. It was featured in Lancet 200 years of important publications. And now it is part of Harrison's guidelines on TB prevention. A sneak peek into the revised guidelines, they are going to come out, the 2013 guidelines. So there is some rewording now, but one of the important things that I would say that will happen is that the household contacts are now part of the discourse. And if patients have severe, moderate, or even mild undernutrition, a comprehensive package should include nutrition intervention, and food basket should be offered to households in case of food insecurity settings and undernutrition. So more than that impact, the lives that we touch, the people who survived because of the intervention, and the lessons that we learned in resilience and humanity in face of sickness and precarity is what I would say is the biggest lesson. Thank you so much.
My pleasure to move on to our next speaker, who is Dr. Karen Dupreez. Dr. Dupreez is a clinician scientist at the Desmond Tutu TB Center at Stellenbosch University in South Africa, where she leads the operational and implementation science component and has done for, I think, over a decade. So over to you, Karen.
Thank you very much, and thank you for the opportunity to speak today and at this really exciting symposium. And it was super interesting to hear more about nutrition. I got the mammoth task of talking about smoking and TB, and I think we can really have an entire conference just on this topic if we really want to give a good synthesis of the available evidence and literature. So this is a disclaimer that I'm providing some snapshot data, but it's definitely not a comprehensive overview of all the available evidence. So just to quickly, for interest, show you, just in the past 5 years, there were 49 abstracts on PubMed. If I only restricted my search to randomized controlled trials and systematic reviews, which we'll know is sort of the highest quality of evidence, right? So there's really, and that's just the past 5 years. There's a lot more data from earlier years as well. But I think the core take-home message is that this is really a dangerous combination, smoking and TB. There's an established body of evidence that smoking increases our risk of TB infection and disease in adults. And globally in 2023, there were an estimated 700,000 new TB cases that were attributable to smoking. If we look at the evidence, there's really an increased risk of infection, of disease, or smoking causes an increased risk of infection, of disease, also of TB mortality. It reduces the response to treatment, or negatively influences the response to treatment. It increases the risk of TB recurrence, and also increases the risk of post-TB disease. If we look at this article that was recently published looking at barriers to engagement in the care cascade for TB disease in India specifically. And this was quite a comprehensive review looking at all the studies from India and looking at drop-offs at the care cascade. And the authors only considered statistically significantly associated factors with unfavorable TB treatment outcomes for at least 2 studies that were informed the evidence for that gap. And if we look at this cascade, tobacco use and smoking really features along the entire care cascade and really impacting poorly on our outcomes and retention of care for patients in TB care. So I take our message. I'm just having like 3 or 4 messages that I want you to remember after the talk. And the first one is that smoking not only increases the risk of getting TB, but also increases our risk of unfavorable TB outcomes across the care cascade. So we all are very well aware that TB affects families. And smoking, however, also affects families. And although it's an individual person who often develops TB or who are smoking, it really is it's a syndemic that, and I think probably in most of the topics we will discuss today, but we have to think further than that one patient or person and really also think about everybody that they're living with. In many high TB burden settings, prevalence of smoking amongst patients with TB, the prevalence is nearly 20 to 30% of TB patients that smoking. So it's really a massive burden amongst families affected by TB, also being affected by smoking. So if we look, so my interest obviously is very much in children and what the effect is of passive smoking or smoking exposure. And there's lots of different, it's called secondhand smoking, passive smoking, environmental tobacco smoke exposure. There's lots of different terminologies, but it really just captures the risk of individuals and specifically our children exposed to tobacco smoking at the household level. And if we first just look at infection, we'll look at disease a bit later. The evidence is, there's a bit of evidence, but it's not overwhelming. But if we look at the first study that I just want to quickly discuss is a cross-sectional household contact study that was done in Gambia using ELISpot as their test of infection. And they used a multivariate model that really adjusted for multiple factors, including an interaction term for the level of exposure and smoking, which I thought was quite interesting analytically. They included 718 household contacts, less than 15 years of age, and they found a 3-fold increase in the odds of TB infection in children who slept closest to a person who smoked within the same home compared to sleeping with a non-smoking person. So really a substantial increase there in terms of the risk of infection if there's also exposure to smoking. If we look at data from our group here in Cape Town, South Africa, and this is actually a study that I'll be further doing with Michaela in the near future, so watch this space. But this is some results from the preliminary analysis. And this was a household contact study from 3 communities, done in 3 communities in Cape Town. And we had 2 different measures of infection. So the one was the TST, another one was IGRA results, and we used quantiferon golden tube and T-spot TB tests. For this analysis, we just combined either or both of them being positive. And we found a really strong association between any household tobacco smoking exposure and the risk of TB infection using either of those tests. There was a more than 3-fold increased risk in children. And then interestingly, I think we also showed some association in terms of the dose response. So with an increased number of household smokers, there was an increased risk of infection. And this was also in a multivariate model adjusting for multiple factors. And I think the most important factor to consider in these type of studies would be your TB exposure and your gradient of TB exposure, because I mean, we know that would probably be the most impactful indicator that would also predict TB infection. But so we actually adjust for that quite comprehensively in this analysis. Okay, and then we also calculated the population attributable fraction. So in these communities, we had an extremely high prevalence of household smoking. So just over 3/4 of children were living in a household where somebody was smoking. But in this setting, with this high prevalence of smoking, 56% of TB infections in children could have been prevented if nobody smoked in the household. And that really just shows us what the potential impact could be in terms of TB control and transmission if we could really include tobacco cessation programs as part of our TB care. So there's some evidence that smoking also increases our risk of TB infection in child contacts of TB patients. If we move on to the effect of passive smoking on TB disease in children, there's a couple of studies as well. It's one case control study from India, which included 60 children with presumed or confirmed TB and 118 controls. They only looked at young kids, less than 55 years of age, and they had a different classification again. They looked at indoor air pollution, and they combined tobacco smoking and biomass fuel exposure, which is obviously also a big challenge. Tobacco smoking is one form of indoor air pollution, but there are multiple other forms that we also need to consider. And in this study, TB was associated with indoor air pollution, about 2.67, but as you can see, sort of just confidence interval close to 1. But yeah, this was even after adjusting for household TB exposure and food insecurity. Then there were 2 systematic reviews and meta-analysis that I thought might be interesting just to quickly talk about. The one were published in 2023, and they looked at risk factors for TB in children, and they looked at 11 risk factors from the studies that they included, and they found a pool odds ratio also of about 2.6 risk for TB disease in children with exposure to tobacco smoking. The only limitation there was that they weren't really able to, they didn't do an individual patient meta-analysis, so they weren't able to adjust for the effect of TB exposure. But again, it's also a very similar effect estimate to what we found in the other studies. And then an earlier review by Patro et al., we also found a more than 3-fold increased risk of TB, active TB, following secondhand smoking. And you can see it's quite a strong association there of 3.4. And they also in this meta-analysis found a significant exposure response relationships, looking at whether it was parents, a parent that were the smoker, or whether they were more crowding in the household. The problem with both of these systematic reviews and meta-analysis was that they both reported a very high heterogeneity. And even in the second systematic review where we found, where we're seeing really a strong association, the authors also said that given the high heterogeneity among the primary studies, they feel that the analysis might not show sufficient evidence to inform an association. And there's also one very interesting study from Spain that was recently published, included 616 children, also less than 15 years. And they also recruited from contact tracing studies, so similar to what we did in Cape Town. And they found that passive smoking was associated with a positive IGRA quite substantially. If you can see there, that was the highest effect estimate that I've seen, so 8.7 times increased odds. And then also that was related to TB infection as well as TB disease with an odds ratio of 3.4. But they also found a very interesting thing, that the egress sensitivity was reduced in active TB patients exposed to tobacco. So that's maybe something we need to consider when we do more studies and using egress to determine MTB infection and the association between that and smoking. So I think we can say that there's some evidence that smoking also increases the risk of TB infection and disease in child contacts exposed to secondhand tobacco smoking and TB. But I do think it's important that we really highlight the fact that we need better high-quality studies, or more high-quality studies, and standardized measures for exposures and outcomes, because that was one of the big challenges doing a meta-analysis on the studies, were that everybody was defining the exposure and measuring the exposure and the outcome differently. And obviously, specifically with disease, it gets really tricky to assign children, because of the fact that we don't have a lot of bacteriologically confirmed children, and most would be a clinical diagnosis. So we really just need some standardized ways to be able to compare the research. And then I think really essential that we think about interventions to support smoking cessation, especially for families affected by TB. And I know Michaela and Katarina is doing very exciting work in Zimbabwe to, as a start, look at a comprehensive package of interventions. So we're looking forward to seeing those results.
So there were some very interesting questions, and this question comes whether it is reviewers or when you are yourself advocating for tools. So our reviewers mentioned, did you do body composition? We did in a subset. So we in places where we work for families with tuberculosis, we do not have the best tools available. So we cannot wait for the best tools, and we have to use what we have. And although the BMI may not be the best tool for overweight obesity, but I still feel for underweight, it continues to be useful. MUAC is a very good, I used to be a great advocate, but I saw that it was very difficult in field situation. So although it was possible for children, for adults, I saw some mistakes happening. So although I have given the value in the chat box, but I would not say on a large scale, especially in the kind of settings where we worked, the field workers whom we could train, this was probably not a very successful tool. So those were the main questions. And yes, micronutrients versus macronutrients. As I say, when we are all working for patients and families affected by TB, nothing is this versus this, and it has to be this as well as this. So whether it is cash or food, I would say cash as well as food, micro, macro. And of course, I would not advocate for ready-to-use therapeutic foods, because that really changes the eating habits of communities. And that's not what an intervention on a large scale should look like. Thank you so much. I guess I've summarized most of the things.
And now it's my pleasure to hand on to our next speaker, Nikita Joshua. Nikita Joshua is a Mararuwu woman, which is from a remote community in the Northern Territory of Australia. She is a TB survivor and has also worked and continues to work to raise awareness, and as a healthcare worker in some of the kind of most culturally beautiful parts of Australia. So I'm absolutely delighted to have her on the call. And thank you also to Dr. Emma Smith, her colleague, who has arranged for Nikita to share with us. Thank you, Nikita.
Hello, everyone. My name is Nikita Joshua. I'm a 20-year-old woman from a small community called Nuka. southeast of Katherine in the Northern Territory of Australia. I am from the Marolo tribe. My language is Mara, and my skin name is Ngarichan. I am joining you today from the traditional lands of the Larrakia people and pay my respects to the elders past and present. I was diagnosed with TB last year. When they found out I had TB, it was already late. The symptoms I had were night sweats, shivering, low energy, loss of weight, and shortness of breath. But it started with headaches. I can sometimes feel the pain when I talk about it. The clinic didn't know what was going on with me. I kept going back and still nothing's changed. The pain was still there, even though they just kept giving me painkillers. My partner used to carry me around the house and to even take a shower because I didn't have the energy to walk around or do things on my own. By the time I was sent out to hospital, I was thinking it was too late for me and I was ready for my life to end. I had very supportive friends and family that talked me through everything. At first, I didn't want to take all of the medicine because it was too much for me. The nurses would stand around and watch me take all of the medicine, which made me uncomfortable to take it. Each time it felt like they were rushing me and not stepping back to give me space. In the first week, I was just refused to take it. I was really scared going through this. It was hard for me for first 2 or 3 weeks. I wasn't allowed visitors. I was scared that the doctors and nurses had masks and gowns on when they came to see me. I felt like I must have a really terrible disease. I spent months in the isolated room in hospital. I wasn't allowed near anyone without a mask for safety. 1 or 2 months passed of taking the medicine. I started to feel stronger, get my energy back, and could do things by myself. I started to gain my weight back after being so skinny. It felt good to be home after spending all of the time in hospital. It's been 9 months now, and I am still taking the medicine today. It's been very challenging for me since I got back. I need to travel and walk to the clinic often to pick up my medicine. My friends and family have been supporting me not to miss any tablets, to make sure I have food to take with the medicine and to get to clinic for checkups. What now motivates me is to let other people know about TB and what it does to your body. Some doctors and nurses don't even know about TB, and it's important that they are concerned about TB in our communities. I am now working as a community TB outreach worker. I hope to teach people about TB by sharing my story and experience. I don't want anyone else to go through what I went through because it will be devastating for them. I wasn't aware of TB and now want everyone in the community to be aware of the symptoms and when to get a checkup. If we all work together, I think we can stop TB spreading in our communities.
Thank you so much, Nikita. We're so grateful to you for your bravery in sharing your experience, and also incredibly inspired by your determination to change the experience for other people in Australia. I can see, Emma, you've also joined us. Did you want to kind of lead some discussion or questions with Nikita?
Yes, please. Quickly introduce myself. My name's Emma. I have the pleasure of working with Nikita in the Northern Territory, and lots of other amazing people on our team who are working in remote Aboriginal communities. And yeah, this was the first time Nikita's ever shared her story in any sort of forum, so I think she did really incredibly well, and was just amazingly brave to hear her tell her story. We thought that maybe some people on this talk might not be aware of some of the difficulties of kind of living in remote community in Australia. And so Nikita thought maybe we could talk a little to some of the complexities and difficulties of living remotely here in Australia.
So what are some of the difficulties of living in a remote community in Australia? Is housing is the biggest problem in our communities. The houses are crowded and there is not enough housing for everyone. People argue about who will buy food or power. Food is also a big problem, especially for people who don't have a caring or supportive family. Food in the shops is very expensive and some of the food is not healthy or out of date. It's not easy for everyone to hunt for their food. Some people also don't trust the clinic and don't really like people touching them. It can be very hard for them to get treatment for their health problems. It is hard for my people to travel. My community is many hours from the nearest town and the road closes in wet season.
Thanks, Nikita. I guess that's some of the difficulties are really, it's incredible how shared a lot of the difficulties are in lots of places where TB continues to be a huge problem. But for us in the NT, there's obviously some specific things too, and some things that Nikita really thinks that we need to focus on in the TB response in communities in Australia. So maybe you can talk a little bit about that, Nikita, as well.
Yeah, people need to give time and space to build good relationships with people in community. We need to build trust and respect between patients and the health workers. I think having local people working in the health clinic is very important. This will help people to understand and have information in their own languages. When Aboriginal people are taken from country to go into big hospitals, it separates us from our cultural ways of healing and getting bush medicines. I think more is needed to make sure people can stay connected to country, family, and other support people during treatment so that we can get stronger and healthier again.
They were the kind of only questions that we kind of wanted to specifically talk about, Michaela, but obviously super happy. I'm sure Nikita would be happy to answer any other questions that people have.
And it is now my pleasure to hand over to our final speaker of the session. That's Professor Stephen Chambers, who is the scientific lead of the Pacific Leprosy Foundation and is an infectious diseases professor at the University of Otago in Aotearoa, New Zealand. So thank you so much, Steve, for sharing with us on the topic of controlling leprosy and tuberculosis in Kiribati. Pacific Leprosy Foundation essentially manages most of the leprosy programs throughout the small Pacific Islands. And if you are from a part of the world that has remote communities, I can guarantee that the separation of islands by thousands of kilometers of Pacific Ocean is truly one of the most remote experiences that can have. And so I'm grateful to Steve for sharing about some of his long-time work in the region.
TV team, which includes some Australian folks, Ben Murray, whom I know, and Warwick Britton, Jeremy, who's organising there, and then these are all the nurses who are running the project down below. So that's been expanded probably since you last saw it, Michaela, and there's a couple of old blokes sitting in the front here. And then on the right-hand side here is the leprosy team. This is the Pacific Leprosy Foundation, which is a very small charity based in Christchurch. It's been going for about 100 years. And the key people here is Jill Tomlinson, who organises everything at the foundation. Arturo, who's a leprosy consultant with WHO, he's a Filipino. And then one of our PhD students, Nick Douglas, who's maybe known to some of you, who worked in northern up in Darwin for quite a while, and Nabura, who's a Kiribati doctor who lives in New Zealand and is now a public health consultant. And here's the leprosy team at the bottom here, Dr. Tamaya, who might be around a little bit, and then Array in the front, in the middle, and she's the lead manager of the Leprosy Foundation. So I missed a couple of slides here, but anyway, just to introduce you to Kiribati, look, it's as incredibly remote as, if you go on Wikipedia, it says it's the most difficult place to reach in the world. And basically, for me to get there means I've got to fly through Fiji and then overnight and then go up to Kiribati. It's another 3 hours north of Fiji, roughly on the equator. And it's very threatened by climate change. And you can see this photograph here. Seems to be missing another couple, but anyway, it's a little girl working across, because this climate change is coming, and Kiribati is threatening to go underwater. And if you look at the map here, the key place is the bottom left-hand corner here, called Beso, and that's where there's a deep water port. It's got a very rich history in the military terms, because that's the Japanese were there, and that was the first place the Americans invaded. So there's a lot of sort of history around it. Anyway, because it was so smashed up in World War II, a lot of people immigrated into the area, and it became extremely highly populated. And you can see the country as a whole is fairly highly populated. It has an enormous sea area, but of millions of kilometres, but it's only got 811 square kilometres. And the population is about 120,000. And the densest place of the population is down here in Beso, where there's roughly 1.4 square kilometres. There's about 20,000 people, and it's all single story. So it's very, everyone is a contact essentially. And it's just linked to the mainland by this causeway, which is built by the Japanese folks. The TB prevalence has been traditionally greater than 500,000 per 100,000 without any active screening. BCG coverage is very high at over 90%, and actually, so we've just done a bit more work on that, and it's looking at the birth records, and actually it's probably close to 98%. So there's very limited contact tracing for both TB, for tuberculosis, a little bit more for leprosy. With leprosy, the new case detection rates over 200 per 100,000. There's been good contact tracing, but otherwise pretty much passive detection, and prevention has been pretty reasonable. So when I first got involved with leprosy, it was probably about 2010, and there was a very active person in the leprosy management system, and he'd gone out and he'd started doing some active tracing. So this D here is when there was this peak of cases. But if you sort of track backwards, you probably don't know the history of leprosy particularly, but basically the so-called elimination phase was never reached by Kiribati, or if it did, it was only for about 6 months. And everyone said, oh, great, there's no more leprosy, it's eliminated, we don't need to do anything about it. And guess what happens if the conditions haven't changed and you stop looking for it and you remove all the resources, the number of cases goes up. And so when you start looking again, yes, you find it. The incubation period is usually around about 5 to 7 years. And so you can see after this phase here, when people stop looking, the number of cases just gradually accumulated. So that was a big deal. So one of the first things we did was to do some mathematical modelling. And basically, the big take-home message of this is that if you just do a single dose rifampicin prophylaxis, you find that there's a rather slow, if you look at that purple line, rather slow drop in cases, but it's quite well sustained. But if you do mass chemoprophylaxis, where you give it to everybody in the community, and in a situation where there's a lot of contacts, you can see that it drops down more quickly, but it's not sustained. And so the notion was, if we could manage it, is to do both household contacts and then to get mass as well. But we only had the resources really to do household contact tracing and single dose rifampicin prophylaxis for them. And so we got going with that in 2018 with both a retrospective and a prospective component. And I won't sort of go through all the details here, but basically what we, because of the number of cases that we had on the records, we found something like 8,000, the number of contacts you can see there was 9,700 retrospectively and 3,800 prospectively. And so the teams went out and they would examine all the contacts of cases going back sort of for 5 years prior to the date of 2018. And you can see we managed to get about 90% coverage. We found quite a few new cases, which is actually very consistent with other people. What they've found is the rate is about 0.4% retrospectively and 0.6% prospectively. So overall, the coverage was actually pretty good. And so the team got a lot of experience about how to do this and how to engage with the communities, because a lot of work going out and then educating people, engaging with the mayors, engaging with the spiritual leaders in the communities, getting acceptance that this is something that's worthwhile doing. And you can see here that actually that very few people actually refused. Basically, it's a very we've subsequently, sorry, I flicked on by mistake here. We're then interested to know what had actually happened to this, and this is some work done from our database, and this is a big deal setting the database up, as you're aware, I'm sure. The outcomes of this, or what has happened over time. And you can see here that what happened is when I looked at all the patients who had had STR prophylaxis, who were listed as contacts, and I looked at all those who were listed as contacts but had missed the STR prophylaxis, we found that when we reviewed all this, 91% of new cases were not household contacts. So this is telling you that single dose rifampicin is never going to control this epidemic. We had to get on and do mass chemoprophylaxis. And it also, we looked at that single dose rifampicin actually did appear to be reducing it. Now, there's been quite a lot of controversy in the literature. Yes, it seemed single dose rifampicin seemed to work quite well if you in a setting of a big research project. But what about in the real world? What happens? And certainly, it seems as though if we there was a clear benefit. And if you look at that Kaplan-Meier plot on the right, you can see that those that didn't get single dose rifampicin in blue are accumulating much more quickly than the others who did. So we felt pretty pleased that that seemed to be giving us a steer that was making a difference. But it certainly highlighted the fact that we're never going to control it unless we actually had some active, much more active case finding, and we had mass chemoprophylaxis. So that's where the Combine project came in. So the folks in Sydney had been looking to extend their research on tuberculosis and got in touch with us and said, well, maybe we could combine this. Hence the Combine project, so we can combine leprosy and tuberculosis screening and implementation. So basically the Combine project, implementation of combined community-based screening and treatment of active leprosy, tuberculosis and latent tuberculosis or tuberculosis infection with mass chemoprophylaxis with single dose rifampicin to reduce leprosy transmission. And so this is how it's been gone about. So it's nationwide. That's actually been just in BASO so far. So cases of tuberculosis are actively screened by doing digital radiography, read by AI, and confirmed by humans, of course. Where possible, gene experts of the sputum to detect tuberculosis, and then testing of everyone else with a tuberculin test. And if that's positive, then they get the standard sort of 12 doses of rifampicin isoniazid. At the same time, screening for leprosy and then treating disease, and then everybody else gets a single dose of rifampicin. So it's a very intensive program with a very a lot of resources required. So it basically combines TB, leprosy, systematic screening and prevention, post-exposure prophylaxis with single-dose rifampicin, and mass administration with single-dose rifampicin if it's not leprosy, TB, etc. And so the benefits of this is it's harmonized TB leprosy programs. It's using rifamycin-based preventive. SDR is cheap and very effective as the add-on. And 21 of the 23 WHO priorities countries have prevalent TB prevalence of greater than 40, whereas in places like Kiribati, you're talking about several hundred. And the programs are and combined programs are going in some other places as well. It certainly makes leprosy control cheaper and more feasible combined with the TB initiatives. So results so far. So far we've registered about 14,600 people. 10,800 or so have had digital chest X-rays. Expert tests much fewer. There's problems with the supply, really, of the kits and so on, and the capacity to do it. TST skin tests have been planted in over 13,000 people. 130 referred for suspicious skin lesions to the National Leprosy Program, which is nearly 1%, which is of those 35 have been confirmed, which gives you a rate of 240 per 100,000. And in worldwide terms, I don't know of anywhere else where 240 per 100,000 has been recalled, although I think some places, maybe in PNG, maybe similar to that, maybe Tuvalu. And you can see, referred to the National Tuberculosis Program, there was 3.3% had tuberculosis, had suspicion of tuberculosis, and then confirmed pulmonary tuberculosis 114, which is 780 per 100,000. So again, these are astronomical figures when you go looking hard for people who are all at risk. Just to give you a little bit more detail on this, I really just go to the bottom line. It's just really you can see, and this is the leprosy referrals and what's happened. And this is the whole program so far, and you can see so far there's been 35 new cases confirmed, and then what's happened to all the others. And so this is just really indicating that the referral system between the program and the leprosy, the combined program and the leprosy program, which are based at the opposite ends of the atoll, are actually communicating quite well, and we've got a good referral program set up. So what's happened over time in BASO is that there's still cases being identified outside of leprosy, outside of the combined program, but you can see the combined study is identifying more and more of them over time, which is sort of what you expect. So the passive detection is going down because the active detection, I think, is taking over, and a high proportion of cases are being identified. So I'm sure you're all familiar with chest radiographs.
Steve, I'll just note you have 1 minute.
In that case, I better get going, haven't I? So I'll just sort of whiz through here. So that we've now sort of administered any mifamycin treatment to 13,000 people, which is 88.4%, which is a pretty good coverage. And the main messages, I think, are that, in a high prevalence setting, community-based screening for active leprosy is feasible and yields increase in early new detection rate. And if you combine active case screening for leprosy and TB, it's feasible and effective in a high prevalence setting. This is a very high prevalence setting, and this provides a platform for mass drug administration, which is required to control leprosy. And this is all dependent on meaningful partnerships. Now, this has been a lot of work. The Leprosy Foundation has been working in Kiribati for probably 20 years before I got involved with it, so it's probably 30 years it's been there. So there's a lot of relationship building going on. It's dependent a lot on local knowledge and capacity building, as well as the external agencies, and going to new technologies. I think you can't underestimate the benefit of adding in new technologies to make a difference. And the locals have been, local people have been especially ready to adapt to this and integrate both the new cases of TB that are identified and get them into the treatment program, which is a huge stumbling block initially because just so many cases, and also identify the new leprosy cases and getting them into the program as well. So it's been a huge challenge doing this. Just a quick acknowledgement of who's paid for this, which is obviously a whole group of people in universities. And I can think particularly at the moment from the Australian Department of Foreign Affairs and Trade, or DFAT. So that's a jumble of a start, but you get the drift that the two things can go together if you organise it well and provide the right resources and make sure you have the adequate technology to back it up.
And we do have time now. We've got about 10 minutes for questions. So I can see that there are a number in the chat, questions in the chat. And I wanted to invite Nikita to answer the first question. So you've already answered it in the chat beautifully, but I just see your response as being something truly important for us all to hear. So Emma Hanan asked the question, how can nurses and doctors better talk to patients about their treatment and precautions to reduce transmission when they have active TB? How can we improve the way we support patients? So I'm curious if you can maybe read out your answer or expand a bit more on it. Thanks, Nikita and Emma.
Yeah, I think doctors and nurses should talk to patients with TB, like give them kind words, positive words, not negative words, because it might turn their heads around and would like not want to take the tablets, because it happens to me. I refuse to take the meds. Like I just threw them away because of how the nurses would treat me, like would just stand there and not give me space to like take the meds. And that just turned my head around, I would just fly all the meds across the room. And I was just like, would tell them to just back off and not come near me. Because of
So what convinced you?
What convinced me was my mom and Dr. Emma like supported me through what I went through when I was in hospital, and would give me like positive words, like to say if I wanted to leave, then you would just take the meds, And my mom didn't want me passing, so she would convince me to take the meds, and so did Dr. Emma did. I had a really like supportive friends and families, but she was there for me from the start, because I never knew anyone.
Yeah, so
I never knew anyone in the hospital, Yeah. But she was there for me.
okay. Oh, okay. So it sounds like just care, like putting the care back in care. Sounds like a good solution, and also the fact that you had a support network and a family who loved and supported you. That's wonderful. I can see that Ria, you've raised your hand. Did you want to unmute and ask your question?
Thanks, Michaela. Hi, Nikita. And I am in awe, and I think you're amazing. And as a fellow TB survivor, I have the utmost respect for you, only because I know how hard it is to get out there and start talking about it. And so just to quickly introduce myself, like I said, I'm a TB survivor. I'm the board member of Stop TB Partnership. I represent communities at the board. And I'm also a filmmaker and a communications person. And after TB happened to me, I made like a gazillion films on TB because I just couldn't believe how messed up TB is. So thank you for sharing your journey, Nikita. It really means a lot to all of us. Just a question in terms of what you just said, and also another one, if it's okay, Michaela. I think the first question is on stigma. And I wanted to understand if you felt like, I mean, being in this remote part of Australia that you are, did you feel like people were stigmatizing you in your community? Did you feel like, there was self-stigma that you were wondering, oh my God, why did I get TB and why am I going through this? So that is one question. And the second is, with directly observed therapy, I think there's a sense of, I mean, as a person who's had TB, I know that it makes you feel like people don't trust you when you're saying that I'm going to take my drug. So why are people like, why is there so much of surveillance, when you should be able to trust that I want to get better myself and, I will take this drug, would you have preferred to have the option rather than this sort of being forced upon you that, I need to have someone watch me take the tablet? Or would you have preferred to have the option of, hey, maybe I need that support, maybe I don't? Would that have made you feel happier? So just wanted to know your ideas. Thank you, Nikki.
Yeah, for me, I felt embarrassed when the nurses would just stand there and take me, look at me and just to take my meds. And in the community, it's not, I don't know, it was hard in the community. They thought that I was going to pass, They didn't even know what I had, what disease I had. They thought that I had cancer or lupus, but it wasn't that. It was TB. And for me, I didn't know TB could make you feel miserable, and not to yourself.
Thank you, Nikita. I'm glad that we had a supportive family, who could really see you through. And kind of on that topic of families, I might ask Karen, if you can please reflect on whether there is an understanding amongst the families that you worked with amongst smoking, that smoking could adversely affect the whole family, not just the smoker. I'm curious if that's part of your perception when working with communities in Southern Africa.
Thanks, Michaela. Yes, so I think definitely the families, especially the caregivers' perceptions, are there that smoking is also negatively affecting everybody in the household. I think where it is difficult is where the caregiver is often also the smoker. And it's so difficult because it is that entire guilty, like how to stop smoking, how to stop an addictive habit, combining with the guilt. And I think that's what's making our intervention so difficult, right? Really to deal with those deeper issues. But yeah, no, there definitely was acknowledgement that the effects are harmful across, but often also, I think, some overwhelmed feelings of how to deal with that, right, within their circumstances, because often these families also have lots of other problems as well.
Yeah. Oh, thank you for that insight, Karen. And I think I can see there are two hands up, but we may have to reserve those to right at the end. I hope Nikita and Emma and Karen and Steve will hopefully be able to stay for our panel discussion at the end, but don't feel obliged if you can't make it. But I might just quickly continue the theme and ask Steve a question about stigma towards leprosy. I think that this is one of the we've spoken about stigma for TB, the stigma of smoking. For leprosy, Steve, you've described quite a bit of success in Kiribati, and I'm wondering how you overcame stigma or what aspects have assisted in helping the community to really desire preventive treatment.
Oh, that's a big question, Michaela. I think the key thing is the experience that the nurses have had of going out to the households. We did a survey a while ago looking at the attitudes of people towards prophylaxis, and basically when we surveyed them, they said, "Look, we don't want our family to get to leprosy, so we really want them to be involved. But they then said we don't want our neighbours to know. So there's clearly and of course that's a big deal in the leprosy world is how far out you go in terms of neighbours. I mean, how do you find a neighbour? And how do you go out? How far do you go out? But they really just wanted their nuclear family or their own extended family, who they knew well, not to get it, but they didn't want anyone else to know. And so just the nurses turning up at the clinic can be a stigmatizing thing. At the household can be stigmatizing. So it's a lot of groundwork gets put into that. And so that's why mass chemoprophylaxis is quite good, because we can say, look, we're not in your community, but you're not identifying anybody. So everyone's up for this because of your high rates. So that's where we, and so they're combining the TB and leprosy thing. And actually, as you're pointing out, TB is quite stigmatizing as well. But as you sort of combine the whole lot together, somehow it diffuses that stigma as long as you've done the groundwork. So I was really quite surprised actually how few refusals. I mean, I think there's only about 8 refusals, I think, for the STR program, and maybe about the same for the whole TB program. So that's been, but in fact, the very interesting thing was when we spoke to some of the families about this, one of the things they didn't know about was the idea of latent tuberculosis or tuberculosis infection. And when we spoke to them, when they took this on board, they often said, we didn't know about that. And now we think it's really important that we don't want to spread it around, get sick and then spread it around. So the idea of preventive treatment for tuberculosis actually was very appealing. They regarded it as a community good. And so it gave us, they started talking about it, and it gradually get some momentum going. So people feel they're doing good for their whole community. Anyway, that's just a wee bit of the insight that we've had from that.
Oh, that's wonderful to hear. And I think we can all kind of react with some claps for our amazing first round of speakers. Thank you so much. Please do stay on, speakers, towards the end for the panel discussion, and hopefully we can pick up all of those beautiful raised questions. All right, Anka, if you wanted to share your screen with our TB survivor video, and if you wanted to introduce it, that would be wonderful.
Thank you so much for the opportunity to share this story. It's great to see so many familiar faces, and I think this event is wonderful. So thank you so much for organizing it. First, I want to say just a few words about how this video came to be. So this comes from a collaboration from Research Center Borstel, the Robert Koch Institute in Germany, the Central Committee for the Fight Against Tuberculosis in Germany, and it also has, and it's also done in collaboration with the Ministry of Health. So it's in a hope of health literacy and information about tuberculosis in the migrant population in Germany. It's about a Romanian citizen who went to Germany to work and got TB somewhere in the process, or activated TB somewhere in the process. And this person is sharing his experience. The part from Research Center Borstel with the film and everything from this project has been led by Professor Christoph Lange, who is also the next speaker in the session. And it's been produced by GOT Films.
Eram în Worms și munceam la hotel. Eram housemeister. Exact pe vremea asta, în luna mai, am început să tai toți boscheții pe afară. Toate florile, toți. La vreo 2-3 zile am început să transpir, enorm de tare, transpiram. Am început să tușesc, să rupea de mine așa o flegmă. Am fost nevoit, domnul director, la vremea aceea, m-a dat afară. Mi-a spus că falsez. I-am spus, eu nu falsez, sunt bolnav. Am slăbit într-o lună.
Nu știa ce are.
Într-o lună am slăbit 15 kg. Și i-am spus, dacă dumneata consider că eu falsez, te rog frumos să mă dai afară. Dar eu nu falsez, sunt bolnav. Că nu, că tu falsez. M-a dat afară, după care am fost nevoit să plec. Ne-am mai avut bani, am venit aici, la Hamburg, pe spusele unor prieteni care îi aveam în Facebook, eu nu puteam să car nimic, doar aveam atât căra soția mea. Eu căram o geantă pe 4 roți.
Ce să observ? Slăbea, vomita, nu mânca. Dar nu știam că este boala asta.
Vino încoace, îți dăm de muncă, avem de muncă aici. Aici am venit, m-am cazat la un social. Cei de la social mi-au spus, trebuie să mă duc să-mi fac raze la plămâni, să vadă dacă sunt sănătos cu plămânii, mă țin în social. Pot dormi acolo. După ce am fost diagnosticat, m-am dus la spital. Normal, m-a luat salvarea, m-am dat jos din salvare, am dat să fumez. Da. Am dat să fumez, a venit o doamnă asistentă și mi-a zis, aici este spital de plămâni, tu nu ai voie să fumezi. Nu vreau să accept boala. Tratamentul a fost foarte puternic. Eu mă simțeam foarte slăbit. Da, foarte, foarte slăbit. Nu puteam să mai merg în picioare.
Da. A fost greu că el la spital, eu am rămas pe stradă, nu cunoșteam în Hamburg, nu de muncă, nu nimica. Că era pandemia, nu-ți dădea voie în spital. Mă duceam în spatele spitalului și îl vedeam de la geam, de sus. El vorbea cu mine la telefon, că el era la etajul 6. Și îl vedeam de pe geam, îmi făcea cu mâna. Și mă duceam și stăteam în autogară, la Zob. Stăteam acolo pe bancă, era frig afară, în noiembrie.
Warum tritt die Tuberkulose bei Menschen, die aus Rumänien kommen, häufiger auf als in der übrigen Bevölkerung? Das liegt zum einen darin, dass bei Menschen, die alleine wegen der Arbeit nach Deutschland kommen, dass diese Menschen wirklich schlecht bezahlt sind, dafür aber sehr viel arbeiten und damit es in dieser Population eine tatsächlich armutsbedingte Erkrankung ist.
Thank you, Michaela. Hi everyone. So my name is Romain Ragonnet. I'm an infectious disease modeler based at Monash University in Australia. I am chairing this session on integrating screening and care. So we have 3 presentations, including Anka's presentation for this session. And just wanted to note that if anyone has questions, you can either drop them in the chat, and I can see that the chat has been very active during the first session, and that's fantastic. And there is also going to be a panel discussion at the end of the session. So the next speaker is Professor Christoph Lange, who is a pulmonologist and infectious diseases specialist from Germany. Christoph is the medical director of the research center Borstel and professor of respiratory medicine and international health at the University of Lübeck. He is one of the founders of TBNet, and today Christoph is going to talk about addressing drug-resistant TB in Europe. The floor is yours, Christoph.
Thank you very much for the kind invitation, and special thanks to Michaela for bringing everyone here together. This is amazing how many people take their time to share their knowledge and emotions, and I'm very grateful that we're allowed to be part of this. Just a question for feedback. Can you hear me and can you see the slide?
Very clearly. Thanks, Christoph.
Okay. In the year 2026, we met at Geneva because IGRAS were just coming up, and we thought how nice it would be to do research together in TB in Europe. The HIV colleagues had done this with EuroCEDA, but there was no collaborative research in Europe. And so in a series of settings, we founded an NGO called TBNet. This is Tuberculosis Network European Trials Group in the year 2006. And with very little money, but a lot of enthusiasm, TBNet is almost 20 years later still surviving. We do have branches for tuberculosis research in children called PTBNet, and also a branch for research in non-tuberculous mycobacteria disease called NTMNet. We now have more than 815 registered members Many of them are not active, but are just registered. And they represent 50 different countries. But we have like a hardcore group of about 200 researchers that collaborate actively. There are 90 peer-reviewed publications, and they're mostly on the topics of prevention, drug-resistant TB, and tuberculosis and migration. Something that we're very proud of is the so-called TBNet Academy. The TBNet Academy, if we have money, is run every year in a country in Central or Eastern Europe. It is bringing together young colleagues under the age of 36 and has the aim to build junior networks of tuberculosis across the European landscape. We also conduct every month a TBNet webinar. Shortly after the beginning in 2007, we took retrospective data on a larger cohort of individuals affected by drug-resistant tuberculosis in Europe to look at outcomes. This was in the year 2007, and we saw that with the, by that time, relevant new definition of XDR-TB, having fluoroquinolone and injectable drug resistance, treatment outcome was less beneficial than in drug-resistant TB, and only about 45% of patients with XDR-TB had treatment success at the end of therapy. Subsequently, in 2011, we had the chance to participate in an EU-funded project called the TB PANnet, where our role was to build a pan-European database on individuals with drug-resistant TB. And we did this in countries of, at that time, low incidence, intermediate, and high burden of a TB with more than 100 per 100,000. You see here these high burden countries at that time, Romania and Moldova, the intermediate burden country at that time, in the Baltics, Estonia, Latvia, and Lithuania, and Portugal, and the other countries were low burden countries. And what we did is we did demographic and microbiological evaluations in an observational cohort database of individuals with drug-resistant TB enrolled in these sites. And at the outcome, we saw what would be expected, that the outcome in XDR-TB is less favorable than in pre-XDR-TB and in MDR-TB. And also, if we would look at reversion after culture conversion, the outcome was less favorable in XDR-TB, pre-XDR-TB, and MDR-TB. However, if we looked at WHO treatment outcomes, we were surprised. Cure was better in MDR-TB than in pre-XDR-TB and in XDR-TB. How could that be if the direct measures were the other way around? So we questioned the definitions of treatment outcome by the WHO and came up with a very simple TBNet definitions of treatment outcome. Basically, treatment success is you have culture conversion after 6 months of therapy and no reversion within 1 year after the end of therapy, or after this six months plus 1 year after the end of therapy. So if we applied these definitions, we actually found that the outcome in MDR-TB was better than in pre-XDR-TB, and that we only had these 40% of treatment success in XDR-TB, and also the treatment failures in XDR-TB were much higher than the other way around. This simplified outcome definitions by TBNet led to change in the WHO recommendations for treatment outcome with a new category called sustained treatment success with an evaluation 1 year after the end of treatment. And we always take the analogy in cancer where an oncologist wouldn't tell his patient at the end of chemotherapy, you are cured, but it needs a certain time at the end of therapy, interval after the end of therapy to see whether cure really happened or not. We also saw that with these treatment outcome definitions, if we took them by countries of incidence, like the low incidence, intermediate, and high incidence countries, by WHO definitions, the cure rate was much higher in the high incidence countries than in the low incidence countries, despite much lower resources. And this was basically because patients were producing sputum, not sputum, but spit, that was required for these 3 negative cultures 30 months apart in the continuation phase of therapy. This was not done in the low burden countries of TB. And if we applied the simplified ACTnet definitions, we found about 60% of cure rates across the board, irrespectively of the level of TB incidence in the region, but we found higher failure rate in the high burden countries. And in a second type of studies that ACTnet does, we looked at costs of therapy. We saw that in the middle income countries and in the high income countries. And please see that here that's the y-axis is very different. The costs for TB treatment are enormously, like for XDR TB, 10,000 euros for in the middle income countries, but in the high income countries, on average, between 100 and 200,000 euros for the treatment of XDR TB. That is similar to a stem cell transplantation therapy in our setting. We also found that in all the countries that were surveyed here from Europe, the costs for MDR TB are exceeding the 50% of all the TB drug costs, with one exception, that is Finland. And here you see the burden of MDR TB, like Belarus and Ukraine, with more than 20% of MDR TB in percentage, but these countries pay more than 90% of the expenditures for TB drugs just on drug-resistant TB. We also found that even 2 years after WHO had proposed the rollout of BPAL-M, only half of the countries had access to the drugs, only half of the countries had access to drug susceptibility testing in the WHO region Europe, which is a scandal in our view in terms of implementation. We are mentioning this in editorials and in public statements like this one, which happened this year in the Union Journal on an urgent request for predominant label expansion, because predominant in the EU is often not available because it is EU labeled only for the old definition of XDR-TB, and it's basically the health insurances are only compensating for it if you have XDR-TB, but the WHO said it's for all MDR-TB, but not for XDR-TB. Very recently, we looked at outcomes in XDR-TB by the new definition, and we saw that while outcomes in MDR-TB and pre-XDR-TB, here those are more than 9,000 individuals in Europe who receive XDR-TB treatment after 2021. So with the new definition, treatment is between 67 and 77%. Treatment outcome is still around 40%. Even with the new definition in XDR-TB. So there is still a lot of room for improvement. And we see here that there is a severe difference whether you come from lower middle income or upper middle income country, which is the Eastern European countries, or from a high income country. Sorry, these are high income countries, and this is the probability of unsuccessful treatment outcome. So if you come from basically Eastern Europe within the European region, the chances of a successful outcome is much less favorable than if you come from Western Europe. So there's healthcare inequality across our continent. We also see a very urgent need for implementation of molecular drug resistant testing to prevent the emerging of drug resistance in the region. And we have an unpublished manuscript out that shows very dramatic increase in bedaquiline resistance in patients who are having treatment failure in the Republic of Moldova. We also see, and this is work where Anka has been involved in, that drug-resistant TB is one of the risk factors in individuals who are migrating to the Western European region. The odds ratio of drug resistance is 3 times higher for migrants with tuberculosis to have drug-resistant TB than from individuals who are born in the region and have been living in the region. And this is further complicating the elimination of tuberculosis in our setting. So with this, I stop. Observational cohort studies that are done low budget in TBNet are mainly addressing outcome matters, healthcare inequalities, and there are healthcare inequalities and a lot of issues on treatment costs even in Europe. And we see that there's not so much a research and development problem at the moment, but we have a huge implementation problem in our region of existing diagnostic and therapeutic interventions. Most of TBNet work is not funded. You can all become members if you want. Membership is for free, and just go to the website and see what we're doing. Thank you very much for your attention.
So the next speaker is Na Nguyen from Vietnam. She's the Associate Director of HIV TB programs at the Friends for International TB Relief, Vietnam. And today she's going to talk about integrating screening in Vietnam. Over to you now.
Thank you so much. Hello, everyone. Maybe I am the last one, right? And so I'm from Vietnam, and today I would like to share with you about our experience with community-based integrated service delivery in Vietnam. And first of all, you can see in the slide, let me brief introduce some key demographic and health indicator in Vietnam for your reference. That Vietnam has a population of 100 million with a median age of 33 years and life expectancy of 76 years. Urban nutrition in nearly 40%, and the per capita GDP in 2023 were around $4,300. And on health indicators, infant mortality is 14 per 1,000 lives, and literacy is 96%. And health expenditure is 4.6% of GDP. And key risk factor here including tobacco use at 25% and alcohol consumption at 8 near per person per year. And the highlight of progress and ongoing health challenges. And the slide show you that Vietnam health system is organized in a hierarchical structure. And you can see at the top, the Ministry of Health provides the overall management and direction, supported by other ministries and health institutions. And at the central level, you can see there are MOS departments, research institutions, medical colleges, and central hospitals. At the provincial level, Department of Health oversees provincial hospitals, medical schools, and Center for Disease Control and Prevention. And below that, district health center and commune health station deliver services closer to community, supported by village health worker at the grassroots level. And this structure ensure both top-down management and local service delivery. However, since July 2025, the district level in Vietnam is no longer available due to some changes in the system, the government system. And in the slide show you that in 2023, Vietnam had about 182,000 TB cases. However, only 57% received treatment, meaning nearly half were missing. While treatment success is high for drug-sensitive TB at around 90%, but it dropped to about 72% for drug-resistant TB, showing major challenges for TB in Vietnam. And TB and non-communicable diseases are both major health burden globally, especially in low and middle income countries. In Vietnam, you may know, we have about 182,000 people develop TB each year, while millions live with diabetes, hypertension, and COPD. Also affects a significant proportion of adults. Management of the comorbidity is fragmented. And in Vietnam, hypertension is usually treated at a common health station, but diabetes and COPD are mainly managed at a higher level hospitals. And even though that health insurance cover up to 80% of treatment costs, but many patients in Vietnam still face high out-of-pocket expenses, and it's creating many barriers for long-term care. And the maps show you our size, and the green areas are implementation provinces. We have 7 provinces, while the red dot indicates our office location and implementation teams. Mainly we located in Hanoi and Ho Chi Minh City, but covering provinces across in the north, the central, and the south of Vietnam. And between 2023 and 2024, we have 118 community events were held across 7 provinces. And we screen people for TB using genetic rate and export testing and link spot positive cases to treatment. And at the same time, we measure blood pressure, blood glucose, and lung function, and mainly for people who is 40 and above. And people with suspected hypertension, diabetes, COPD were referred to public health facility for confirmation and care. And this way, TB and NCD screening were integrated in one setting. And the slide shows you about our photo from the integrated service delivery events. So you can see local community participating in TB screening, blood pressure, glucose testing, and counseling, all happening in one place. And this is key findings. So, and this slide summarizes the outcome from the integrated screening. And so you can see at the top, we mobilized for over 30,500 people with risk factor, and around 30,000 disease generated screening, and over 2,600 were abnormal. And after further testing, we detect 240 TB cases, and most of them start on treatment and preventive therapy for NCD screening. We have over 26,000 people had blood pressure screening, and nearly 7,000 were positive, and over 4,700 diagnosis with hypertension, and all of them almost started on treatment. And for the diabetes, we have over 15,000 had glucose testing, with over 1,000 were positive, and as 163 were diagnosed with diabetes, and they also linked for treatment as well. And the last thing that we have over 6,500 spirometry tests, and finally we detect 90 people were diagnosed with COPD or asthma, and most of them started on treatment as well. And so overall, that we see that this the data shows that how integrated screening can identify both TB and common NCD and link patient to care. And the next slide shows you the yield of TB and NCD by age group. And you can see that the TB yield is very low across all ages and below 1%. So 1% here. And but TB infection is more common and around 15%. About 11% here. And in adults, and for hypertension, prevalence rises sadly with age, and from 19% in people, 19% in people under 15 to 30% to 30% in those who are above 65, and diabetes and COPD are also concentrated in older group, and with around 12 and 11% that are positively in those people with over 65 years. And so on, why TB disease were so rare, and NCD, especially hypertension and diabetes, increasing significantly with age. And this is the Venn diagram, is the diagram. So the overlap between diabetes, hypertension, TB, and COPD, and the lag is single burden in hypertension. You can see is about nearly 65%, and diabetes alone is around 9%, and TB or TB infection is about 30%. And in the total, and we know that we detect that over 8,230 as participants were diagnosed with only one disease, but 992 either were diagnosed with 2 diseases, and 50 cases were diagnosed with 3 diseases, and that only one participant were diagnosed with 4 diseases. And from IFD event, we realized that there are 3 main challenges emergence. Firstly, health facilities were easily overburdened because screening identified many people with diabetes, hypertension, diabetes, and COPD, while resources and local staff are really limited. And secondly, the TB teams, they have to support NCD confirmation and treatment linkers, and we reduce their focus on TB care. And the third is that I at the event are one-time activity, but NCD patients require long-term follow-up and creating a sustainability gap in terms of both capacity and funding for local. And in conclusion, this service delivery model reduces access barrier by offer multiple free screening tests in one visit, and saving participant time and their money. And it also reduces stigma and compared to TB early events, and make better use of resources, supports continuity of care across different diseases. And last but not least, we would like to acknowledge our collaborator, including lung hospitals in 7 provinces, district TB unit health, community health station, and we also thank Ministry of Health and TB and provincial people committee in 7 provinces and for their approval. And finally, we grateful and acknowledge funding support from the Stop TB Partnership TB Street in ETS. Thank you for the attention.
Thank you so much for the presentation on integrated screening in Vietnam. I'm curious if you found that by integrating with TB, that removed or reduced community stigma and that you had better uptake. Did you have a sense of what services people were attending for, what was the biggest draw card? Thank you.
And thank you for the question. And for the first question, I saw on the chat box, and I think that the health event only provided screening, and there were a lot in the time. Okay, okay, and I think there were not enough time or capacity for proper care initiation. So one person with a positive screen will refer to the relevant care provider or for treatment initiation. So I think, and for the second question, I think yes, absolutely. That was one of the first learning that we make when we start with the health events, and integrating NCD changes what you to be a TV event to a primary healthcare event. So we far more relevant to the generation population and take away the focus on the stigmatizers and disease of TB.
Yeah, thank you, Laura, very much. I just repeat that briefly. The question is on the rise of bedaquiline that is now being observed, and bedaquiline being part of many regimens that are currently under investigation. I think that is actually a real threat. We see from comparison or indirect comparison, for example, in the truncate TB trial, that bedaquiline may actually be the best medicine against TB that we had in history. A bedaquiline-based regimen led to 2 months, or used for 2 months, had non-inferior outcomes than 6 months HRZE. That drug changed morbidity and mortality on large scale in South Africa and in other countries. We see that without bedaquiline, treatment regimens are much longer, and treatment outcomes are also poorer in drug-resistant TB. Now we observe approximately 10% of bedaquiline resistance already in the Western Cape. We have very little bedaquiline resistance in Europe, but recently we observed emerging bedaquiline resistant in patients who fail MDR TB treatment. And this is dramatic. About 50 in Moldova, we see among 1,000 patients with drug-resistant TB, 50 of them only have unsuccessful treatment. So 95%, or of the 95%, about 70% have positive outcome, so have success, and there are few deaths and few transferred out. But the 5% who have unsuccessful treatment. And in these 5%, there is already more than 15% baseline bedaquiline resistance and about 50% fluoroquinolone resistance and about 15% linezolid resistance. And on treatment, we observe the same on top again, so that in the end, those 5% who fail treatment, 80% have fluoroquinolone resistant TB, 50%, 50, have bedaquiline resistant TB, and more than 30% have linezolid resistant TB. They cannot be treated with any drugs that are currently available. They may be sent back home to the communities where they may be infecting family members and others. And I think we're currently at the dawn of a new XDR TB epidemic in Eastern Europe, which is just happening while we speak. The only way to prevent this would be to implement very rapidly targeted next generation sequencing in these countries that are highly affected, to at the earliest time point identify M. tuberculosis drug resistance and try to change the regimens so that each and every individual who is affected by drug-resistant TB only receives medicines to which the bacteria are susceptible. That would be the only way to stop these emerging resistance. And it is of great concern, and that was the question, that, for example, in Unite for TB, which is the largest platform for drug trials worldwide at the moment, almost all of the regimens are bedaquiline-based. We have very, very few alternatives, and we need to invest much more into alternative regimens that are without bedaquiline. There may be hope for, with a new substance from the TB Alliance that may overcome this low level or intermediate level bedaquiline resistance based on RV0678. The last word on that is not out yet, but we need to expect that much more bedaquiline resistance will be seen in certain areas of the world in the near future. I saw Deborah Wambe from Eswatini is also here on the call. She can present on bedaquiline resistance in Eswatini, which is dramatic in those who have rifampicin-resistant TB. So this is something that will not go away. I was asking about the diagnostic algorithm when DST is done. So they are now implementing next generation sequencing by targeted sequencing in Moldova, but they don't have it yet really implemented. So they have Gene Expert. If the Gene Expert shows TB and rifampicin resistance, they start to put the patient on BPAL-M. If they have cartridges, they also add to use the same sample for the XDR cartridge from Cephite. So basically to identify fluoroquinolone resistance or isoniazid resistance, but the regimen will be the same BPAL-M with or without M. So I think that XDR TB cartridge is highly overrated because it doesn't really change the regimen. That's what they do. And then down the line, Moldova has really very good laboratory. Down the line, then they will get phenotypic drug susceptibility testing and resistant testing. But be aware that this RV0678 mutation causing bedaquiline resistance that wobbles around the ECOF, the ecological cutoff. So it may show actually susceptibility, but it's very close to the cutoff. And these strains are not fully susceptible, but they are already resistant. And nobody has shown yet that really with high in a clinical trial that with high dose of bedaquiline or with normal dose of bedaquiline you can overcome those resistance. In opposite, there's very good evidence that if you give the standard dose of bedaquiline in the presence of this mutation, that this is causing treatment failure.
I would like to move from drug resistance testing now back to the first part of our session, which is a bit looking into all of the different comorbidities that might, or I'm not sure that smoking can be called a comorbidity or like co-situation. And would like to switch to Karen. So there have been several very interesting different in the different presentations. Almost everybody mentioned smoking. So Vietnam has a prevalence of smoking of 25%, for example. Then obviously in India it's also quite a big problem, and yet it's not really captured very often, I feel, or not in a very systematic way. So if you could design a perfect trial to assess the effect of smoking on TB infection and disease, what would it look like?
Sure, Laura, that is, I thought Michaela's question on the ethical obligation we have in terms of incorporating interventions is difficult, but this one's probably even slightly more difficult. I think I think in terms of adults, we actually have enough evidence that we don't need any more evidence of the associations, right? And we actually need to have action. So a trial to really intervene. And I do think that it is almost unethical / impossible to only intervene on one of these aspects at a family or household level. We can't only do smoking cessation, right? We actually need to look at nutrition. We need to look at other substance abuse challenges. We need to address poverty. And the problem is that smoking sits within this group of challenges that these patients that's affected by TB often also struggle with, right? So yeah, so I think you're asking me a difficult question, but I think what Michaela and Katrina is doing in Zimbabwe, where they're actually doing a trial to really address multiple of these, and maybe she could also speak to that, Michaela. It would be good to hear your thoughts on this. But where they're trying to address multiple factors, right, and not only smoking. I think that would probably give us the biggest impact in terms of reducing the impact of smoking and all of these other factors on TB transmission and TB control. I don't know, Michaela, do you want to jump in there a little bit and tell them about what you're doing?
I think I can hand it over to Claire, who's on the call. Claire, did you want to unmute and just share a bit about smoking cessation and the RESTORE study?
Hi, yeah, sure. So yes, hi everybody. I'm Claire. I also am one of the investigators as part of the RESTORE study, which is a cluster randomized trial which has recently been funded with joint funding from MRC in the UK. Oh, I can start my video. Hi. So yeah, the RESTORE study has been funded by MRC in the UK and Australia as part of the Global Alliance for Chronic Diseases. And essentially it's a multi-morbidity centered intervention for people with TB integrated into the routine TB clinic service. And we're going to deliver it a cluster randomized trial over about a year. And it includes smoking cessation. And yeah, we've had a lot of these conversations. And I really loved what you were saying, Karen, about we can't just do one bit of it. We have to kind of think about how these things go together. So I think it's going to be really interesting. The intervention is going to include psychosocial support, so essentially a food card and social support groups led by TB survivors, smoking cessation support, diabetes screening and treatment, mental health support. We're really lucky to be doing this in collaboration with Friendship Bench, which is an excellent model of community-led mental health services. And then sort of an adapted version of pulmonary rehab to think about physical disability and recovery from chronic lung disease. So yeah, very happy to talk more about it.
I'm very much looking forward to the results of the RESTORE study. And I agree, it is difficult because you actually want to be able to disentangle what are the differential yield of each of these interventions separately, right? But I think TB is just, in terms of the social and sort of wider, I don't know what to call it, sort of social constructs, challenges of TB households, it is extremely difficult to disentangle those and what is actually the main driver. And, you know, so even if you address it, are you really addressing, is the impact you're seeing only from that one thing? So I'm really very excited about seeing the results from the RESTORE study. So Laura, did that answer you sufficiently?
I mean, it's a bit of a rhetorical question as well, right? I think it's very difficult to answer a question about what would be the perfect trial. But yeah, I think a lot of the points that we touched today, and especially what you two now discussed as well, is it just shows that TB is primarily a social problem. There are also obviously medical challenges to it, and especially all of the discussions around drug resistance and all of these bits are also medical, biological issues, but there's a massive social aspect to the whole disease, definitely.
And maybe Laura, if I can, sorry, can I just add there? I think the other really crucial thing is what we talked about earlier with Nikita, that it is sort of really supporting patients, right? Because I think even smoking cessation, it sounds like such an easy solution, right? We know it's bad, but still it is so difficult for people to stop. And I think often we as healthcare workers, you know, we are sometimes lacking the compassion that our patients really require for us to help them to have changed and to make decisions that has long-lasting changing effects in their lifestyle. And I mean, we've seen this in hypertension and obesity and lots of other challenges, right? It is, yeah, so it's really a much more complex, but it's not that we should stop trying, right? We should definitely keep on going and bringing in our patient voices and thinking about the ways we deliver these interventions and services. And I think importantly also, there's not a one size fits all, because some patients might require different interventions, even for smoking cessation. Some might might respond better to behavioral type interventions, and other might need additional nicotine patches or something. Others might just need more mental health support, right? Especially if there's other substance abuse. I didn't even show that, but a lot of the articles that I looked at smoking and alcohol use. So I think we often put smoking outside, but it is actually part of this bigger substance challenge we have. And I think it often goes very closely with mental health challenges.
I completely agree. And this also links in very much to what Nikita has shared about her experience, right? That she felt very much under pressure because a bunch of people were standing in front of her and like just looking at her while she was trying to take her drugs. So I think Michaela also asked a bit more towards Nikita's experience here again. So did you experience any kind of other support during your treatment, which was not only looking at TB, but at other things of your life?
Nikita's gotten shy. We were just talking about it between the two of us, and she was kind of, I guess, reflecting that she felt that was pretty lacking in her care overall. Is that in the end there was lots of support for treatment and how we were going to get through kind of TB, but little kind of support or consideration for the other aspects. And as she alluded to, food security is such a big one that we probably don't give enough support and thought to when we're, certainly from in our context in the NT.
I mean, that was a very clear answer, right? You don't need a lot of words sometimes to make it very clear as well, right? So, and I guess that is one of the biggest problems we have in clinical care in general, right? A lot of times we just look at our specific silo and we don't really think about the context too much. So there's only 1 minute left of this great first day of the symposium. Seeing that a lot of people are very late in their day already, I think, end it for now and thank especially all of our panelists for sharing their data and their experiences in such a wonderful way, and all of the audience that have engaged so much in these discussions that we've been having. Also, obviously, to the organizers, which have done a great job. And just to remind you that this is only the first of 3 wonderful days. So tomorrow, same time, same place. Don't miss it. Thank you so much and have a wonderful rest of your day.